Thank you. Dr. Walton.
Thank you. I too welcome this report. I think it's a great step in the right direction. We've still got a lot of paradigm shifts to do. I think I'm here really because I believe I've had the privilege to lead on probably the development of the only comprehensive primary care mental health service in the country, which actually supports GPs, works with GPs, links with the communities. And I just want to make a warning about relying on health and wellbeing boards. That sounds a bit top-down to me. I think if we're going to get things really working, what we did, we walked the streets, we met the patients, we asked them what they need. We had meetings where we sat patients next to commissioners and they actually asked commissioners, why can't I have these services? And we worked with all the diverse communities. I think we've got 102 languages in Samwell. And I'm proud to say that if you do this right, you can match demands with needs. And by actually meeting the communities, it's not always the communities you think need all the help. You really have to build it up from there. What's happening in the country is GPs are meant to see over 90% of the figures I get is 93% of consultations for mental health problems are in general practice surgeries. And yet we have somewhere around 3% of the money to support general practice and to support primary care. And I think there needs to be, I'm going to say this of course as a GP, but I think there needs to be a huge shift of resources. And a lot of that 3% is IAP services, which we're talking about, improving access to primary care, to psychological therapies, which in most cases are actually run from secondary care and given to primary care rather than work alongside. And so we made ourselves quite unpopular with IAP by saying, well, hang on, yes, we want the investment, yes, psychological therapies work, but you're only really offering us CBT, which probably works for a good proportion of people, and it's too rigid. We've listened to our customers, and actually they're all individuals, and they all need individual things, and some of them actually hate CBT. And so we made a whole range of therapies, and we ran lots of pilots, which was the only way we could do it at the time. We had more pilots than British Airways, we used to say. And what we did is we evaluated everything. We evaluated with well-being scores, and we evaluated with a psychological measuring score, core score. And we found everything's worked, practically. And the patients were able to find what suited them. But we also said, well, hang on, psychological therapies, they work, but they don't work very well if you're homeless, if you're in debt, if you're not up Maslow's hierarchy. Actually, so what we need is to link services in with debt advice and so on. And this starts getting very complicated. And then we said to the users group, what services are out there? Because actually you know better than us. Okay, and we linked with libraries. We linked with the voluntary sector. We suddenly found there's huge resources out there. So it doesn't actually have to necessarily cost a huge amount. But this means commissioning with lots of different people, and CCTs get a bit confused about that. And it means that we have to commission, not procure, because you have to bring these services together. And then GPs, I hate to say this, we're simple people. We can't keep up with all this happening. People send us letters all the time, please send to my services. Well, unless I have a patient who needs those services in the following 5 days, I just forget about it. Or if I do refer a year later, I find the service is gone, it's moved, it's not being funded, it's disappeared, and I get an angry patient back saying, why did you waste my time? They don't want to know. So we've linked it all through a central hub. So all I have to do, and all my GPs have to do, is actually fax something into a central hub. The hub brings the patient and says, these are what we can offer you. And then we have these patients. My patients are complicated. They don't come in with just one thing. They don't read the textbooks and get proper illnesses. And so what do we do with them? And these people are in chaos. And when I did my research, what works in primary care mental health? The answer, I'm afraid, is lots of things work a little bit, but one thing works a lot. And that's link workers. And that's someone, we call them the esteem team. And the esteem team goes up to the patient and says, I was like you once. A lot of them are users who've recovered, or they're certainly from the local community, they understand the local community. you've got to get off that couch if we're going to get you better. Are you going to do it, or I'll stick with you until you do? Because if you were a child bringing the housing department on a 845 number, I'll help you do that. Okay, we can't afford that. Let's go up to the housing. I will come with you on the bus. They have bus passes. Right? And they stick with them until they get better. And link workers work. And we've got some wonderful examples. And all this is relatively low cost. And we're talking about early intervention. Early intervention works. Where should we have early intervention? Why have we got these services where you have to reach a level of illness before we can get into secondary care? Because secondary care haven't got any money, so they're raising the bar higher and higher and higher. And you know, when you bring them up as a GP, it's not, well, can we help this patient? We'll change this attitude. So, well, do they really fit my criteria because I'm overwhelmed and I can't cope? And we change that criteria with our services. You know, we know that that our patients want to enter our services because we're nice to them. And they stay in primary care. They don't get stigmatised. Or if they have to go to secondary care, we stick with them and make sure they're able to come back because we've got the services to bring them back. But all this is, you know, against the problem that the council is stripping the support services as we speak. So we know as we speak, because we can't get our patients the support from the council services, they're coming to us, and we're having to refer them higher up the chain. We also know this works because Assam was one of the few places in the country where we are reducing our lengths of stay in mental health mental hospitals. And all around us, CCGs are buying expensive beds in the private sector because they're overflowing. The other thing that we need to do, and it says in the report, thank you very much, education of mental health for medical students all the way through, I'm afraid is not good enough. If you, this paper from Birmingham University, they asked 500 medical students coming through Birmingham University, when you are GP, who are you going to spend your time with, the diabetic or the schizophrenic? Right? And no surprise, they all said, well, the diabetic's going to listen to me. You know, we're going to get some success with them. The trouble is, when they become GPs, that doesn't necessarily change that much. And it's not just GPs, it's through all the medical. You know, we have stigma in the medical profession, I'm afraid. And so we need education. We need education on cases, and this is what we do. I mean, I run education courses. We educate about half our GPs in Samuel. And we know they come on our education courses, the whole practice refers 50% less into secondary care because they start getting interested in these patients, hearing their stories, and understanding that it's changing the stories of, you know, what makes them better is solving their underlying problems and helping them live an individual life, the one that they choose, not the one that we think is right for them. That's what we've got to do. I think that's the well-being. So well-being, yeah, it's written through this report. And I've got to thank Lisa Hill, who's the commissioner, who I was lucky to run into, who dragged me away from the medical model and said, hang on, it's more than just medicine. You know, these patients need all the 10 steps to well-being. And they do. And they deserve that. And this political climate is very difficult. But we need more and more to push it in the right direction and to tell the world that actually everyone deserves well-being. Thank you very much.